Getting ready with the computer, since we have a good number of audience, I take this opportunity to thank once more the entire organizing committee and Navle Hospital. Believe me, they've given everything free to us. This auditorium, the venue, everything has been given free to us, and it shows the generosity and magnanimity to promote academics in this country. And I also take this opportunity to thank the entire organizing team led by Sandeep Diwan, Sandeep Mutta for their great work in making this conference such a big feast academically and otherwise. How many of you are awake here? Oh, very happy. Yes. And how many of you think you have encountered inadequate brachial plexus block in your journey? You should give a big clap because everybody has been very honest. There is a reason behind this clap, to wake up all those who are sleeping. And it's such a major issue that inadequate brachial plexus block haunts us always, because we always relate it to our ego. If the block fails, we relate it to our ego, and we never wanted our surgeon to know that the block is inadequate. You agree or not? And we put the blame on the patient. Patient is very anxious, patient is very young. The block has almost taken, except for a small place, there is little bit inadequate, and then we put the screen, and except you, nobody else knows that there is an inadequate block. And being an anesthesiologist, we know how to camouflage this, but we have lovely drugs like ketamine, fentanyl, midazolam, propofol, which we say I gave only very little for decreasing the anxiety, and eventually we know how much we gave, only we know how much we gave. So I think it's a burning issue, and it's an important problem, and I think we need to earnestly address this. And I also, when I start, I would like to start to share with you. I've shared the story much before also. 2 years ago, there was a shoulder dislocation in one of the hospitals in Chennai, heart of Chennai, not a rural place. This young boy, 24 years old, he was an engineering college student, finished, joined Cognizant Technology, got his first month pay. Saturday was a holiday. He was helping his mother, fell down, had a shoulder dislocation, was taken to a nearby hospital, was told it was nothing. The orthopedic surgeon and anesthetist will come and do the case, and the anesthetist gave a block, paresthesia technique apparently. I spoke to him because this patient was a distant relative of mine, and the block didn't work. The surgeon was in a hurry. He tried to reduce the shoulder dislocation. He was not able to, because there was no muscle relaxation. And as we normally do, this anesthetist gave little bit of combination of drugs, and the surgeon tried again. Patient went into profound laryngospasm because it is inadequate, and he did not have enough support in the system because he thought it's only a shoulder dislocation, and this patient died on the table. This is not far away from now. It is just 2 years back. This young 24 years old boy died because of an inadequate brachial plexus block. And we were not willing to shed off our ego, and we wanted to prove that it worked. So it can cost a life. It's definitely not a joke. So it becomes very pertinent and important that when we do something, we should aid the patient, and it should not result in a morbidity or mortality. So now, how do we encounter, how do we do our brachial plexus block? God has been very kind in having the plexus together. Unlike the lower limb, in upper extremity, the nerves lie in close proximity. With one injection, you will be able to give a very good block. And if you block it at the level of the root, you call it as an interscalene. If you block it at the level of the trunk, it becomes subclavian perivascular. If you block it at the level of the cords, it becomes infraclavicular. If you block it in the terminal branches, we call it as axillary. So it's very important that the block room this is our block room. We always keep the resuscitation equipments ready, the drugs ready, the monitor ready, so that we prevent an eventuality happening because of the block. And first I thought we would start with why an inadequate block. So I thought I will demonstrate one common block that we do normally, that is the interscalene block. Can you get the audio? able to define the interscalene groove correctly and place the local anesthetic solution in the groove will surely get a very successful block. How to identify the interscalene groove? Let me demonstrate this on a 50 years old patient who has come with a fracture in the forearm. Now, if I could show you the anatomy, here you see the sternal notch. You see the sternal head of sternocleidomastoid. You are seeing the clavicular head of the sternocleidomastoid. Then this is the clavicle and this is the head of the humerus. Now, what is more important is to identify the groove, and the way I do it is in relationship to the lateral head, the lateral border of the lateral head of the sternocleidomastoid. Now, to begin with, you have identified the sternal notch. If you just go up, you palpate the cricoid, and cricoid is at the level of C6. From the cricoid, you just bring your fingers back at the level of C6, and when you cross the lateral border of the lateral head or the clavicular head of the sternocleidomastoid, tell yourself that you have to go another 1 to 1.5 centimeter laterally. And then if you see that now I am at a place which is roughly about 1 to 1.5 centimeter lateral to the lateral border of the sternocleidomastoid, and here I am palpating the apex of the scalene triangle, scalenus anticus medially, medially and the scalenus medius laterally. So I am at the apex. If I take out my finger, you can see the external jugular vein is crossing the apex of the scalene triangle. In 95% of the times, you always see the external jugular vein crossing the apex of the interscalene groove. So once again, I am going to palpate. So now I am palpating it more than once. I want to make 100% sure. I roll my finger so that I am palpating the belly of the anticus and the belly of the medius. Having done that, the next thing I am going to do is, I am going to stretch the skin slightly. Because it's a very labile skin over the interscalene groove, many people make a mistake if they don't make the skin taut there. When they introduce the needle also being blunt, there is a possibility that the needle doesn't enter the groove correctly. So now I have identified the groove, rolled my finger, made sure that I'm feeling both the anticus and medius. I have stretched the skin here. And the nerve stimulator that I'm going to use now is the Stimuplex DIG machine, which you can see there. This is the basic version. I've kept a milliamps of 1.5 milliamps in the peripheral nerve stimulator. Here you see the positive electrode which is connected to an ECG electrode. The negative electrode is connected to the Stimuplex needle. So now, since the circuit is complete, I am palpating the apex of the scalene groove, and I'm just going to tell the patient, so I'm trying to introduce the needle into the. So now, as you see the contraction of pectoralis major, deltoid, biceps. I'm slowly decreasing from 1 point. Okay, so this I thought I wanted to tell because many of the workshops I've seen that invariably the inadequate brachial plexus block is because of inability to identify the interscalene groove correctly. Most of the time the mistake that is made is you go between the groove, between the lateral border of the sternocleidomastoid and the scalenus anticus, and invariably you get a failed block. The next common mistake that is done is you go more lateral to the interscalene groove, where you stimulate the dorsal scapular nerve, the nerve to levator scapulae and trapezius. If you use the nerve stimulator, there will be a violent movement of the upper limb, but you inject the drug, there won't be any block. So please, when you use an interscalene block, make sure that the pectoralis, the deltoid, the biceps and the triceps, 2 of the 4 is contracting for you to get an extremely good quality of block. In the same breath, I would say that if you are using interscalene block, If you master interscalene block, you will get 100% block in all your cases with few additions. This is what I want to mention. Suppose if you are using an interscalene block for a clavicle fracture, you should substitute this with a superficial cervical plexus block, or what we call it as a supraclavicular nerve block. You should take the midpoint of the lateral head of the sternocleidomastoid and inject 5 ml here. It's mandatory if you do a clavicle surgery. If you are using an interscalene for a shoulder procedure, it is important to substitute with intercostobrachial block. This is the cutaneous distribution of the intercostobrachial. So in a proximal humerus or in a shoulder procedure, this part you have to cutaneously infiltrate. Otherwise, in spite of having a good block, when the surgeon puts an incision, the patient shouts in pain. So this area has to be infiltrated. Then in shoulder surgeries, especially when they do shoulder arthroscopies, it's important to substitute interscalene with suprascapular block. Then when you do a distal elbow procedure, this posterior part, the cutaneous distribution is not blocked properly in most of the conditions with interscalene. So interscalene has to be combined with, this is a infiltration that you need to give between the middle third and the lower third, about 3 to 4 ml here and 3 to 4 ml. This is a T-shaped infiltration above. So surgeries of lower humerus and olecranon, this becomes important to make your block complete. And whenever you use interscalene approach for any procedure below middle third of the arm, it's important to you combine the interscalene block with C8T1 block in the axillary. That is below the axillary artery. You go, get stimulate the ulnar or radius, give 10 ml there. It becomes a perfect block. So inadequate block doesn't arise when you substitute adequately with the additional blocks that needs to be given. When you given a block, normally the block ascends from proximal to the distal. These parts go first, then the distal part. So after giving the block, don't try to ask the patient to move distally. Within 2 minutes of an interscalene block, ask the person to lift. If he is not able to lift his shoulder, that means your block is taken. Then you check at the elbow. Ask him to flex or ask him to extend. Then you will see that whether it is taken or not. But for a complete block to take, we're using a peripheral nerve stimulator, it might be about 15 minutes before you declare that there is an inadequate block. Now, how to check whether the block is adequate or not? That I think many of you know, but I want to repeat for the postgraduates. You do not take a needle and put multiple punctures and see a sea of blood coming out everywhere. So please abandon that and you go for the test of 4P. Now, this is ask the patient to push against resistance, and this is done by the extensor. There is a triceps which is supplied by the radial. So ask him to push against this, and if he is not able to do it, the triceps muscle is relaxed and the radial nerve is blocked. And ask him to pull inside against resistance, and if he is not able to do, the biceps is blocked and the biceps is relaxed and the musculocutaneous is blocked. Pinch him in the medial part. If he is not able to feel the sensation, the ulnar nerve is blocked, and pinch him here in the second finger. If he is not able to feel the pinch, the median is blocked. This is called the test of 4 Ps, an easy way to find out whether your block is working completely or not. And if you notice that one particular nerve is not blocked, then it becomes important to go for what is called as rescue block. So where do you do the rescue block? The rescue block, you do it in the axillary region. All of you are very proficient in doing an axillary block. So the rescue block has to be given in the axillary region. You are below the artery. You are below the artery. It's a good mnemonic. That is ulna and radius. You are is below the artery. So you palpate the artery, fix the artery, go below the artery, and majority of the time you know that the radius, if you use a the needle that you use, it's a blunt needle, so when you push it with force, invariably you end up getting a triceps contraction. Do not withdraw it to get an ulnar contraction. Keep it there and inject 10 ml. So if you do that, the radius will get blocked, ulna will get blocked. If you want to block the median, then you should go above the artery. Fix the artery, go through the upper margin, put your needle above and try to get a median response, which is a flexor response of the wrist. And the brachioradialis. So if you want to do the median, then you should go above the artery. And these 3 nerves are within the sheath. But the one nerve that is outside is the musculocutaneous nerve. Those who attended the workshop yesterday will know that how to do that block. But for the benefit of others, it is like first you fix the artery, just go above the artery and block. You will see the median response. When you get the median response, imagine that the tip of your needle should go about half a centimeter superior encephalate to its current position. Above the vessel, you push the needle inside, you get the median response. When the musculocutaneous is spared, what you do is, imagine that you push your needle tip half a centimeter superior encephalate to the current position. Then you will get the biceps contraction, and that's the musculocutaneous block. If you master individually blocking these individual nerves in the axillary, it will work as a rescue block for you, and there is no need to give ketamine, propofol, midazolam, fentanyl in an unprotected airway. I mean it. So at the end of, you will know whether your block is taking or not within 3 minutes when the shoulder they are able to move or not. Within 15 minutes, you know which nerve is spared, and whichever nerve is spared, you give a rescue block here. And there are various other options which are available, and we can block it at the elbow. But more simply, if you try to master one thing like axilla, if you master it, and you can do it in the axillary region, especially so because you will be able to use the tourniquet. And with the advent of ultrasound guided regional anesthesia, things have become much better. The inadequate blocks have become less, but initially in the learning curve it's difficult, but you saw plenty of lectures, and with Professor Vincent Chan explaining the drug spread, which is very vital to get an adequate block with an ultrasound. Do not believe that all the blocks given by ultrasound in the learning curve works. It's not the machine. You know, when there is a block failure, there is an excellent statement. When there is a block failure, do you concentrate on the distal end of the block or the proximal end of the block? What is there in the proximal end of the block? The person who is giving it. Okay, so it's very important to realize that. So the machine won't make the difference, the person will make the difference. And even with ultrasound guided regional anesthesia, it's very important to see the drug spread is adequate. It's a very good idea to use the dual mode so that you will never make any mistakes in your block, because you will stimulate the nerve, you will see the drug spread. So those who are embarking into ultrasound guided regional anesthesia, please use both together, low currents, and it will result in an extremely good block. Actually, there are multiple pictures which I could share, but I think my time is getting up. But these are all available for you freely in the net. Every block is available. The drug spread is available. It's a big learning experience for you. Just go to the YouTube. You type anything that you want. Everything is freely available. It's just for you to go and invest some time on that. And also mentally, one of my suggestions is, if you're going to do a block that day, go to the YouTube the previous day. 5 times see the block. Mentally think over the block 5 times. And when you go and put your probe, the nerve will be in front of you. I mean it. You do it, I mean it. So that will be an extremely good way to block it. This is in the forearm, out of plane, in plane, which you have heard many a times. But I end my speech by saying that inadequate block, embark on a rescue block. If the rescue block doesn't work, please protect our own egos to the block, and the surgeons honestly know what we have done, because they are very intelligent. You might probably think they do not know, but they will tell to others other than us. So do not try to satisfy him. Being honest will go a long way, and they will appreciate it. I'm sure that you all will become members of this Academy of Regional Anesthesia, because regional anesthesia is going to change the way we practice anesthesia, and site-specific analgesia will become the norm in the next few years. Let us be the part of a journey which will end in a beautiful destination of an excellent patient care for critically ill patients with least problems that we give to them. And those who wish to become members of AORA, we have a counter downstairs. And also I take this opportunity to invite you for the 2014 Academy of Regional Anesthesia meeting in Delhi. Together we will make anesthesia safe to our patients. Thank you very much.
And this will be again a lecture on the complications related to brachial plexus block. You'll be wondering why I keep on talking on complications, because this is a topic which is not being touched by many people. They don't want to reveal themselves what they have faced in their routine practice. So I thought this could be one of the talks that I propose in this conference. And there was a statement made to me by my surgeon, who's a very good friend of mine, and he's an orthopedic surgeon, and he used to always say that I allow you blocks because you can handle the complications of blocks. So that is an important statement made by your surgeon friend. Coming to the